Good afternoon. This is the first presentation from our series. Thank you for coming and attending. The subject today I choose it simply because I was interested to know a little bit about how to manage delirious patient when I was working in UK, and now when I finish my rotation in consultation lesion psychiatry. It's very interesting subject, and it's practical. It has, as you see, 4 parts. First, let's give you a little bit background about delirious. How do you diagnose? What's the type? What's about the risk factor, the prevalence, and the outcome? The main part, which comes from the mostly guidelines, 12th edition, about using antipsychotic, typical and atypical, benzodiazepine, and cholinesterase inhibitor, and other drugs. The third point will be general principle, and the last, the conclusion from this lecture. As you can see, for as acute confusional state, it's a common, serious clinical syndrome, characteristic by disturb in consciousness, disturb in cognitive function and perception. It develops over 1 to 2 days, short period, usually with the fluctuation course. That means the patient presented maybe normal. After 1 hour, he will develop hyperactivity, agitation, hallucination, violence, and then presented as low mood apathy. It's a serious medical condition that is associated with poor outcome if not treated well. It's about 15 to 20% of all hospital admission. As you can see, patient with delirium has a longer hospital stay and higher frequency of complication, usually like infection and bed sore, and usually remain still now underdiagnosed and poorly managed. Up to 2/3 of the cases are missed. And the case I presented today, this morning, was one of these cases. Delirium is preventable and treatable if dealt with urgently. I'd like to see the DSM-5, the latest one. Delirium comes under a title, neurocognitive disorder. They have a criteria. One of them is inattention, develop over a short period of time with a fluctuated course, disturbance in cognition, no other neurocognitive disorder, and there should be evidence from the history, physical examination, and lab investigation, and due to general medical condition. They divided it also in several types. One of them, substance intoxication delirium, substance withdrawal delirium, medication-induced delirium, delirium due to general medical condition, delirium due to multiple etiology. In DSM-4, they didn't put it under neurocognitive disorder. This is which is a new term. It was delirium, dementia, due to other. Very important here, when you diagnose delirium, you have to specify, is it acute from hour to days, or it is a chronic, lasting weeks or months? And specify which type. Is it hyperactive, that the person presented agitated, with delusion, disorientation, which can be confused sometimes with schizophrenia. Hypoactive type, which is sometimes very difficult because it can presented, looks like depression, and this is where the difficulty, we cannot differentiate. Usually it comes with apathy, depression, and confusion. And there are mixed type, the patient fluctuates between 2 things. The other one category will be other specified delirium and under specified delirium. The prevalence, about 10% on admission to hospital. The other one, after admission, will increase from 10 to 30%, post-operative up to 53%, intensive care unit, which can be high, 87%. The prevalence on medical wards is about 20 to 30%, and the surgical ward up to 50%. In long-term care, the prevalence is under 20%. Risk factor. Usually the people, you look at the people who could have delirious, if they were male, more than 65 years old, have cognitive impairment, presented with this previously, they have severe illness, multiple causes, and sometimes using more than 4 medication. They say also, this is from one of the series I found, drug use impacted near half all of the cases, and dependence such as people who dependent on benzodiazepine and alcohol. The outcome, if not treated, it can reach mortality up to 18%. So this is a medical emergency, should be treated. Up to 60% will suffer cognitive impairment and increased risk of dementia. Now this is the main core here in presentation from the mostly guidelines. Which medication to use? We are talking here first antipsychotic, typical and atypical, first generation. It's a well-known, evidence-based, haloperidol is the first line of treatment. They recommended now we should do ECG before giving haloperidol to avoid sudden cardiac death, cardiomyopathy, and to monitor QTc interval. We start with the oral dose, 0.5 to 1 milligram, and it can be every 4 hours to increase, 0.5 milligram. IM, it will be between 0.5 to 1 milligram, and observe every 60 minutes and repeat if needed. You monitor the adverse side effect, extrapyramidal side effect, and the longitudinal QT interval. We cannot give haloperidol in people who have delirious tremors and benzodiazepine withdrawal and Lewy body dementia. Avoid using it IV. But here in medical side, in Sabah area, in ICU, they give it IV. And they give it just to manage the aggression and the delirious state. And they have continuous monitoring for that. If we go for atypical, I choose the first one, quetiapine, because we usually give it here. It's the second choice after haloperidol. Oral dose, 12.5 to 50 milligram. And it can increase every 12 hours. Maximum dose, 200 milligram per day. And if it is well tolerated. It is used in ICU to decrease need for IV haloperidol. It may increase the risk of stroke. This is still not approved. It's question mark. Common side effect, sedation and postural hypertension. This is the second choice. The third choice will be the olanzapine. They say here you can start with oral dose, 2.5 to 5 milligram, maximum to 20 milligram per day. It will evidence-based that increase the risk of stroke in elderly people more than 65 who has also dementia. You have to watch for extrapyramidal side effect, which can be lower rate than haloperidol, but it's mostly known sedation. The third one will be risperidone. The oral dose you can start 0.5 milligram PD with additional dose every 4 hours. You can have up to maximum 4 milligram per day. It can increase risk of stroke among elderly people with dementia. This is like olanzapine. It showed, according to evidence-based, poor response in people more than 70 years old. The common side effect, extrapyramidal side effect, and hypotension. Epiproprizole, it was a try, and they start with 5 milligram to 15 milligram up to 30 milligram, but it's very limited evidence-based here. It's increased the risk of stroke in elderly, again questionable. The problem with epiproprizole in delirious patient, it can cause akathisia and worsening sleep-wake cycle. Also, they use amicepride, and they start with 50 to 300 milligram once daily, up to 800 milligram. It is very limited based evidence. You have to monitor renal function. If you have somebody in renal unit, you have to avoid giving this. In elderly patients, it may increase the risk of stroke. Zeprizidone, in UK they don't use it, but some research found that it can help if you give 10 milligram every 2 hours up to maximum 40 milligram per day. Very limited evidence, and it may increase the risk of stroke. Now if we look at the benzodiazepine, the role of benzodiazepine in delirious patient in when they have withdrawal from benzodiazepine and alcohol. We cannot give benzodiazepine people who has delirious due to a general medical condition. First, lorazepam, oral or IM, the dose will be 0.25 to 1 milligram every 2 to 4 hours, maximum to 3 milligram per day. Sometimes they use lorazepam IV in emergency. They have to be careful because it can cause respiratory depression, over-sedation, and paradoxical excitement. It is used in alcohol withdrawal, in neuroleptic malignant syndrome, and Parkinsonism disorder associated with bronchofunctional and worsening delirium symptoms in a clinical trial, because they tried these in people who has delirium due to general medical condition. They found it not very helpful. Diazepam is another choice. The oral dose from 5 to 10 milligram. In elderlies have the dose 2 milligram to start with, used in alcohol or sedative, withdrawal disease, neuroleptic malignant syndrome, and Parkinsonism disease. It has longer half-life, more than lorazepam, preferred in alcohol withdrawal, but it can worsen delirium symptoms. So only used in alcohol. They also try something like cholinesterase inhibitor, anti-dementia medication, like donazepam. And these, here the report was very limited and show no clinical evidence for donazepam, like 5 milligram once daily. It causes nausea, vomiting, diarrhea as common side effect. Rivastigmine, oral dose 1.5 to 9 milligram once daily. Historically, it was used to treat delirium and Lewy body, but not anymore. Lewy body, yes, but not delirium. They thought about other medication, melatonin, 2 milligram per day, very limited evidence-based, used to correct the sleep-wake cycle. Sedation is the most common side effect. Trazodone, anyone use trazodone here? It's used very well known in UK. It's 25 to 150 milligram per noct. Over-sedated is the problem. A limited experience in uncontrolled trial. Interesting here for me was the sodium valproate, because they used to give it oral, IM, IV. I heard that in Egypt they give it IM, IV, but we don't have it here. Start with 200 milligram PD and increase according to plasma level. It can be used when antipsychotic and benzodiazepine is not working. Very few cases prove that it can help. Contraindicated in an acute liver disease. This is all the psychotropic medication use. The next point would be the general principle. Now, when you approach the patient and you think, when you assess the patient according to confusing assessment method, you thought, okay, I will start something here, either psychotropic or benzodiazepine. Keep the dose to the minimum. Use one drug at a time. Build up the dose according to the body side, age, and degree of agitation. We have to build it to reach the dose. Sometimes we think that, okay, we give, for example, quetiapine, 12.5 milligram. We have to think, is it enough or to continue to build up the dose? We should start as PRN, not regular first. So you see if the patient will benefit from it or not. Review at least every 24 hours. So we can review 4 to 8 hours, and then we can review at least 24 hours. Maintain the effective dose for 7 to 10 days and then discontinue, not forever. Ensure the diagnosis and the management of delirium is written, documented, also when the patient is discharged. The conclusion here, it's a serious medical condition and need urgent intervention. To treat delirium, we need to treat the cause. Patients are vulnerable and they are very difficult to be cooperative sometimes. We should follow a clear guidelines to manage delirium. It is common scenario for error that sometimes we miss the diagnosis, we couldn't manage it very well, excessive overdose of benzodiazepine or medication. Don't assume that elderly people or learning disability, they have cognitive impairment. You have to think delirium and treat. Now, to give you an idea, if you want to find more, these are. I took some information, like 70% from mostly guidelines, the others from NICE guidelines and clinical management and prevention of delirium and oath. And that's all. Thank you. I try to make it more practical, simple, so everyone will get something that will be very helpful. Because what I face when I go, like seeing a patient who has delirious, I was thinking, what treatment to use, what the dose, for how long, and to be clear, after you look through the investigation, you decide, is it, and the difficulty also was, if the patient is delirious, is he hyperactive or hypoactive? And this is where sometimes the struggle between the 3D, delirium, depression, and dementia.